Cool. So this is where we left off. Last time we went through all those different reflexes. We did brachial reflex. We did the brachial radialis reflex. We did the patella reflex. We did the triceps reflex, calcaneal reflex, all that stuff. So those are going to be your deep tendon reflexes. Now, to summarize what we covered last time, we were talking about the stretch reflex versus the Golgi tendon reflex. When you have a stretch reflex, you're basically seeing the interfusal muscles are getting stretched. Right? The purpose of the interfusal muscles compared to the extrafusal. Extrafusal is going to be motor control, right? Voluntary motor control and contraction. The intrafusal muscles are going to be involved in regulating that type of control, right? So if you start stretching out the muscles too much, intrafusal fibers are going to get activated. So you're going to see increased motor neuron activity in those intrafusals, and then the muscle is going to contract in order to protect the muscle from overstretch. Now, Golgi tendon reflex, again, that's also another protective mechanism. When you have too much excessive force, right? If you're lifting a dumbbell that's too heavy, or you're lifting anything up that's too heavy for you, the Golgi tendon reflex is going to be initiated. You're going to see a reduction in motor neural activity, and you're going to see the muscles will relax as a consequence. Right? The whole purpose is to prevent from overuse of the muscle, aka muscle damage. Now, the spinal cord circuitry is also going to be involved in things like movement, for example. Whenever you're moving, there's going to be two major phases of your lower extremities. You're going to have the stance phase and a swing phase, and they're going to be alternated between the two. And your flexors and extensor muscles are the ones that are going to be involved in this process, right? They're going to be activating in a reciprocal type of fashion. So I'm not going to hold you guys accountable for all that's going on here, but again, you see the flexors are going to be activated in the swing phase here versus the stance phase that you're going to see more extensor muscles being involved in that process. So that's going to be a study using cat models to be able to see how these extremities are going to be working together, right? The extensor and flexor muscles in your lower extremities and how they allow you to move. So if you want to read more into this, feel free to do so. Again, I'm not going to hold you guys accountable for how the muscles come into play as an animal or a human is walking. You can also see something similar in locomotion with other types of organisms like lamprey, for example, and leeches. They both have an undulating type of movement where they kind of basically sway side to side, and that's what allows them to move in the water. The lamprey is an interesting organism. It's a very, very rudimentary animal. It's also referred to as the vampire fish. Reason being, it's a parasite. It's a parasitic fish. And you find these in a lot of different areas. Like you find it in like the Great Lakes, for example. In certain cultures, they actually eat lamprey, which is super gross, in my opinion. But, to each their own. We dissect these in my Bio 415 lab. And, they're pretty unsavory characters. So they basically latch onto fish and they just, drink their blood. That's why they're called vampire fish. They're also cartilaginous. They don't have any skeleton in them, so it's all cartilage. But they have lots of muscles, and the muscle is what allows that undulation type of movement. The ganglion that are going to be involved in that, these are the segmental ganglion, and those are what innervate the different axial and hypaxial muscles in these types of fish. And so it allows for propulsion. And leech propulsion is going to be very similar. So leeches are going to have a very similar type of movement as these lamprey and vampire fish. I'm not going to play this video, but if you want to watch it, feel free to do so. Watch it on your own time. Again, these are the muscles that are going to be involved and how they cycle back and forth. So it gives you kind of like a sinusoidal type pattern in their movement, right? And these are the different ganglion and, the different neuronal pathways that are involved in that. So again, this is just FYI. If you want to read more into it, feel free to do so. I am not going to hold you guys accountable, so we're not going to go into that in too much more detail. Now, when it comes to upper and lower motor neurons, again, upper motor neurons is brain and spinal cord. Everything out of the spinal cord, it will be your lower motor neurons. So that would be, for example, nerve roots and your peripheral nerves as well. If you have an upper motor neuron lesion, what are the signs and symptoms of that? Upper motor neuron? Rigidity. Yeah. So it's going to be rigid paralysis, right? So you're going to have spasticity, right? So rigidity and spasticity. What about your reflexes? Yeah. So you're going to be hyperreflexic. Lower motor neurons is the opposite, right? So upper motor neurons think everything goes up. Your muscle tone goes up, the spasticity goes up, your reflexes become more exaggerated. Lower motor neurons, completely the opposite, right? You get more flaccid paralysis and you get hyporeflexia. Now here's lower motor neuron syndrome. This is where you get damage to the lower motor neurons. Again, this is going to cause paralysis. This is going to cause weakness. This is going to cause reduction in the overall tone of the muscles involved. How do you diagnose this? You're going to diagnose it through electromyogram. We briefly talked about electromyograms in the past, but it's coming back again here. Electromyogram, whenever I saw this in the clinic, I only saw this once in the clinical setting, and it was to diagnose a patient with ALS, right? Amyotrophic lateral sclerosis. But EMGs can be used for a lot of other different types of studies as well. So it can be used as a diagnostic tool for lots of different things. Other stuff you might see with lower motor neuron syndrome is going to be fasciculations and fibrillations. So basically spontaneous twitching of the muscles that are involved. But long story short, you are going to see paralysis and weakness in muscle tone. Upper motor neurons are going to be a little bit different, right? So I have this nice chart here that talks about the different types of effects you would see, right? You don't have fasciculations, right? Whereas with fasciculations, you see that in lower motor neurons. Again, you see hyperreflexia compared to hyporeflexia, right? So hyperreflexia in upper motor neuron lesions. Here is your electromyogram. Again, in a clinical setting, they're going to be using needles. They literally poke the needle in so they could stimulate neurons and see when they stimulate those neurons, what motor neuron groups are going to be stimulated. They can also see how long it takes for that stimulation to result in a contraction of the muscle, right? So remember, different motor neurons are going to have different firing speeds, but on average, it's like around 50 to 70 meters per second. So it's almost half to 3/4 length of a football field within 1 second. That's how fast that signal gets sent. And that's how long it takes for you to get a muscle contraction, right? 50 to 70 meters per second. So it's pretty fast. If you have a lower motor neuron lesion, you might see that slower, right? You would see that slower in different types of conditions, especially demyelination conditions, right? If you demyelinate, you're going to lose the speed of that signal. Now, again, here's another chart that basically summarizes all of that. Upper motor neuron lesions, you get hyperreflexia. You also see a positive Babinski sign, right? Remember, with the Babinski sign, that's where you take a blunt object. It could be a pen, it could be your thumb, it could be the bottom of one of those reflex hammers that we used last week, and just run it along the plantar surface. And if you see the toes constrict, that's normal. If you see the toes fan out, that's a positive Babinski sign. Okay. Again, you see this also in young kids. We talked about this already in neurodevelopment, right? With young kids, they have not properly, developed all the myelination for their axons yet, up until about the age of 1 to 2, and you will see a positive Babinski sign in young kids. But it should go away in early adolescence into adulthood, right? Now, motor neuron disease that affects both upper and lower motor neurons would be ALS. This is like the ultimate motor neuron disease, right? It's affecting both upper and lower motor neurons. So it's literally causing atrophy of upper motor neurons. So this is amyotrophic lateral sclerosis, which means none, myotrophic, which means basically like the integrity of the muscle, and lateral sclerosis because it's involving the lateral corticospinal tracts. So this is a horrible disease, right? It's generally a death sentence. I'm pretty sure I told you guys my ALS story before, right? With a patient that came in who was attempting to get disability because he wasn't able to work anymore. Did I tell you that story? Okay, so this was when I was doing my internal medicine rotation. I was definitely interested in doing neurology at the time. And so while I was doing my internal medicine rotation, first we were just doing regular internal medicine. So we saw this patient. He was like 45 years old, really nice guy, African-American teacher. He was a high school teacher, and he was trying to file for disability because he was not able to work much. And so when you file for disability, you have to get a medical clearance. So you have to go into the hospital, you need to see the doctor, they need to do a workup on you just to make sure that you legitimately cannot work. Now, part of the workup was doing a neuro consult. So like while my internal medicine team was in there, the neurologist comes in from the hospital with his like little electromyogram machine. And so he's actually like poking and prodding the patient, putting like the little needles in there and doing EMG studies on this guy. And so you could already see that he had Cushing syndrome. Cushing syndrome is a disease that affects the adrenal cortex, and it affects cortisol, the whole cortisol system. And for him, he got it because he was taking corticosteroids, because they already knew that there was something going on that was inflammatory. There's an inflammatory component to ALS. And so he was already on corticosteroids. So he was, with Cushing syndrome, you get obesity in the body, but like your appendages start wasting away, right? You start getting muscle wasting. So your like extremities are basically becoming atrophied. You get fat redistribution to like the abdomen, to the back of the neck. They call it buffalo hump. Also moon face, like the face tends to be very round. And that's from taking corticosteroids for a long time. So that already happened with him. And so anyways, long story short, I started seeing this neurologist on a weekly basis. I would go in during his outpatient clinic. And like 3 months later, he pulls my colleague and I aside. We're both, fourth year med students. And he's like, hey, I just want to prep you guys for this next patient. This guy is coming in and I'm going to be giving him a diagnosis of ALS. And usually a lot of people feel very emotional when they get that diagnosis. It's basically a death sentence. Most people die within like 3 to 5 years of getting diagnosed with ALS. And he just wanted us to be prepped for that emotional type of situation. So in comes the patient in a wheelchair, and it's the same guy. Like, wow, I saw you like 3 months ago. Do you remember me? It's good to see you again, etc. And then the doctor sits down with him. He's like, hey, listen, we've done like an entire battery of tests. We've tried to see what other diagnoses you might have, but we basically arrived to the conclusion that you have ALS, also known as Lou Gehrig's disease. He's like, do you know what that is? And the guy was like, yeah. But he was like not emotional about it whatsoever. And the way that I think what might have happened with him is that he's a smart guy. He was a school teacher, and people go to Google and do Google search all the time on things that happen to them, right? It's always cancer, right? Just kidding. No, but you do a Google search like that, and he probably already kind of had a feeling that he had something like ALS. And so I think for him, it was just kind of like basically a confirmation of what he probably already knew. And like I said, this is a death sentence for most people, unless you're Stephen Hawking. He's a very rare exception. Most people do die at a very, early age with ALS. One thing you see with ALS is you see lots of deterioration of the motor neurons. Then you also see just wasting away of the muscles. Eventually, you have a difficult time swallowing. You also have a difficult time breathing. And these patients generally die of respiratory issues. And there's no cure for ALS. ALS is progressive neurodegenerative disease. There's no going back. You can try to help alleviate some of the symptoms of ALS, but you're not going to cure it. And I'm pretty sure I played this video to you guys before. This was the TED Talk video that goes into the details about motor neuron disease. So I'm not going to play that today. You can watch that on your own time, but I do want to cover more ground today. So going into some of the other aspects of ALS, again, it's you get muscle wasting, right? You also get the scarring of the lateral corticospinal tract. Why do people get this? We don't know. It's idiopathic, but it does happen more often in men. And generally speaking, the age is going to be anywhere above 40 years of age is when a person gets diagnosed. Sometimes it runs in the family. 10% of cases will be familial. What is the neurotransmitter involved? Glutamate is thought to be involved. Glutamate in high concentrations is actually very toxic. And so if the neurons are being exposed to glutamate for too long, they're eventually going to start to get destroyed. So glutamate, of course, is important. It's the most important excitatory neurotransmitter. We're going to talk about glutamate versus GABA quite a bit when we get into basal ganglia. So you need glutamate, but you don't want too much of it. If it doesn't get cleared out, it's very, very neurotoxic. These are some of the genes that have been associated with ALS. So it's been found that there's a superoxide dismutase gene that could be involved in that. And so that's going to basically result in too much oxidative stress. Oxidative stress is associated with lots of neurological diseases. It's been thought that Parkinson's, Alzheimer's, any of those like neurodegenerative diseases are very much associated with oxidative stress, especially at the level of the mitochondria. Mitochondrial dysfunction is very much involved in a lot of these disease processes. Other things, there might be a dynactin gene mutation, which involves the microtubules and cytoskeleton, right? That's going to affect axon transport. Remember, you need like dyneins and kinesins to allow for things to get moving along the extension of the axon. So if you have that, you might also see RNA aggregate as well. So that might be another mechanism. Other ones that might be involved. So the tank binding kinase might be involved. Glutamate uptake, again, that's going to be very much implicated. So the most important thing I want you guys to be familiar with is glutamate when it comes to ALS. Okay, I'm not really extremely concerned about these other genes. Yes, they might play a role, but there's a lot of genes involved in this process, and it's a little complex. So we're not going to go there, but definitely know your glutamate. These are some of the signs and symptoms you're going to see. You're going to see diminished strength. You're going to see muscle atrophy. You're going to see cramps. You're going to see slurring of speech, so dysarthria, dysphagia, difficulty swallowing, spastic paralysis, and flaccid paralysis. Remember, this is upper and lower motor neurons. So you're going to see a combination of both, hyperreflexia and hyporeflexia. This is the other thing that's interesting. You don't lose your intellectual capabilities. You can still think. You can still have regular cognition. Your eyesight is still preserved. Right? Your thoughts are still preserved. Right? Obviously, with Stephen Hawking, he was able to still think up until the very last moments of his life. Right? He was an academic for his whole entire life. How do you test for this? You can do, again, nerve conduction tests. So you can use EMG, right? So electromyograms. You can also look at the individual with an MRI. You can try to take meds that can help kind of stave off the progression of the disease, but it's not going to cure the disease by any stretch of the imagination. So riluzole is a drug that basically blocks glutamine. Right? So it blocks glutamine. And so that's how you get a little bit of like slowing of the progression, but it's not going to fix it. So here's basically the summary of the pathophysiology. The main thing, again, that I want you to focus on here is glutamate, right? Glutamate-mediated toxicity. So this would be excitotoxicity, right? Because it's an excitatory neurotransmitter. Oxidative stress would be another good thing for you to keep in mind too, because oxidative stress is involved in a lot of diseases, right? That's why they say take your antioxidants. Right? Antioxidants are going to be very helpful in mitigating these types of processes. You find that in like goji berries. You find it in even red wine, for example. Lots of foods have antioxidant properties. Tea, green tea especially. Mitochondrial dysfunction is going to be heavily implicated here, and other things too, like axonal transport, etc. But the main ones I want you to focus on are the first two there. All right. Any questions on ALS, Lou Gehrig's disease? Cool. All right. Let's do maybe like one or two quizzes questions and then move on to the next part of motor neurons. As a study guide? Yeah, absolutely. The stuff that I put in the quizzes are definitely going to be things that you might see on the final. All right, let's go ahead and begin. All right, so someone is doing some weightlifting. All of a sudden, they start getting cramps, muscle spasms in their bicep while they're trying to lift something very heavy. They get this abnormal increase in tension within the muscles. Proprioceptors are going to be activated, and then you get a reflexive inhibition of muscle contraction, right? And basically just relaxation. So you drop the heavy object, right, to protect the muscles. So that's going to be the Golgi tendon organ. This is the Golgi tendon reflex. Are we good on that? Awesome. Let's do one more, and then we'll make a move to part 2. Good. I think I honed that in pretty well for you guys. Good job on that. Awesome. So let's go ahead and end the session here. Glutamate, that's what's involved in ALS. Good job on that. Now let's do part 2. Switching gears here a little bit, but kind of going over similar ideas, some things that we have already visited in the early weeks of this class. So this is some of it's going to be a refresher, some of it's going to be some new information, but we're going to be now talking about the upper motor neuron control, so brain and spinal cord. Now here's an overview of all that. We're going to again revisit the lateral and medial tracts. We're going to revisit cortical spinal and cortical bulbar tracts. We're going to talk about the different regions of the cortex that are involved in motor control, right? So premotor cortex as well as the actual primary motor cortex. We're going to briefly discuss motor mapping and motor muscle fields. We're going to talk about mirror motor neurons, which I think are really, really fascinating, right? Where you literally see someone do something and those areas in your brain are actually like being activated just by watching someone else make a movement. So, that I wouldn't be surprised. But yawning is, even just thinking about it makes me want to yawn, right? Yeah. That's funny. That might involve a lot of different things. I mean, it could involve mirror neurons in the insula. I don't know. I'm not sure, but maybe. Who knows? I'm curious to look into that. That's a really good question. Then we're going to talk a little bit about the brainstem, anticipatory maintenance of posture. So, like when you know you're about to do something, certain muscles in your body will contract to help stabilize you during that movement. And then we're going to talk about upper motor neuron syndrome. So we talked about lower motor neuron disease in the last section. Now we're going to talk about upper motor neuron syndrome, which involves things like spinal shock, for example. And then we're going to, again, revisit the Babinski reflex. So here is the motor cortex. Remember, this is pre-central gyrus. right? Remember, the central gyrus is what divides the frontal lobe from the parietal lobe, right? Then you have the precentral gyrus, which is going to be your primary motor cortex. And in front of that is going to be the premotor cortex, which is going to be kind of like an association area for motor control, right? So this is kind of where you're like formulating the idea of maybe like wanting to make a movement. But then when you actually execute the movement, that's going to be predominantly moderated by that primary motor cortex. Now, revisiting those tracts. So you have your upper motor neuron tracts. So you have the lateral tracts and the medial tracts. When we talk about the lateral tracts, this is going to be like really, really like define a definitive, granular, skilled type of movements, right? So anything that requires like, very nimble type of manipulation of things, right? So fine motor control. Versus the medial tracts is going to be more things like posture, right? Maintaining balance, maintaining locomotion. So it's medial tracts. So lateral tracts, maybe one way for you to think about this is like laterally, far away, that's going to be like your fingers. Medial tracts, think about the medial part of your body. That's like your axial musculoskeletal system, posture, right? Balance. Again, when it comes to the spinal cord itself, it goes medial to lateral. Medial is going to be more proximal musculature. The further you go laterally, that's going to be more distal. So the tips of your fingers will be more on the lateral sides of those ventral horns. Whenever you get to your like hypaxial muscles, which are important for maintaining posture, those are going to be more medial. Now, remember, the cortical layers are going to be in 5 layers for the most part. The majority of the cerebral cortex comes in 6 layers. And there's going to be cortical layer 5 here is where you have the Betz pyramidal cells. These are the largest of all neurons, neurons within the central nervous system. These are going to be involved in the cortical spinal as well as the cortical bulbar tracts. They're going to go through the internal capsule. The internal capsule is, I don't have an image here of it, but it's basically just white myelinated tracts that go through like the striatum. We'll talk about the striatum when we get into the basal ganglia later. But it's just basically part of your myelinated tracts. And then it's going to allow for movement of facial muscles as well as the movement of your skeletal muscles throughout the rest of the body. So recall the cortical bulbar tract is going to be face, right? So muscles of expression, they're going to be represented by the cortical bulbar tract. So cranial nerve 7, right? Muscles of expression. Cranial nerve 5, right? Your muscles of mastication for chewing, masseter, temporalis muscle, as well as cranial nerve number 12. And then cortical spinal tract, again, that's going to be involving the rest of the body. And recall that you have the tracts going through the brainstem, so it's going to go midbrain, pons, and medulla. Then it gets all the way down to the very end of the medulla, the caudal medulla, and that's where you get the decussation of the pyramids. That's where they cross over down to the rest of the spinal cord. And then it's going to go to the opposite side, right, the contralateral ventral horn of the spinal cord, and then it's going to eventually synapse with the lower motor neurons, right? The moment it gets out of the spinal cord, that's when now you're entering lower motor neuron territory. So there we go. Here's an image of that. So that's the internal capsule. It's going to go through a bunch of these different nuclei that are making up the subcortical regions of the brain. These are all part of the basal ganglia right over here, which we're going to talk about next time. And so you have your motor neurons going down that internal capsule, and then they're going to go down to these different tracts, right? The golden lines over here, those are going to be your cortical bulbar tracts, innervating the muscles of expression as well as the muscles of mastication. And then you have your lateral cortical spinal tracts, which go down to the medulla and then eventually decussate at the pyramids and then go all the way down to the contralateral side to the rest of the body. Now, with the cortical bulbar tracts, this is something that we're revisiting, right? If you have a central lesion from like a stroke, for example, you're going to see a very unique type of paralysis. It's only going to be on the lower quadrant of the patient's face. on the contralateral side. Versus if you have a peripheral lesion due to, for example, Bell's palsy, then you're going to see the entire half of the face being paralyzed, eyebrows included, right? If you ask the person to lift their eyebrows, they're only going to be able to lift it on one side. And that's because you're getting bilateral innervation to the upper half of the face when it comes to the central motor neuron pathways. Whereas peripherally, it's only going to be unilateral to that one side of the face, so you're going to get total paralysis of the upper portion of the face. Again, recall the arteries involved in providing blood to these regions. Middle cerebral artery, extremely important for several regions in the temporal lobe, the parietal, as well as the frontal lobe. Right? So if you get any sort of occlusion to that, then you're going to see paralysis, right, of like your facial expressions, right? You're going to get slurring of your speech, right? You might also get paralysis, like hemiparesis of one side of the body. And then cingulate motor area, the cingulate gyrus is going to be very much associated with like emotion. So it's going to be lots of like emotional type of processing. You can even get like emotional processing involved in like movement as well. That region is going to be supplied by the anterior cerebral artery. Now, here's one thing that to keep in mind. The amount of fine motor control required of the musculature is proportional to the amount of motor cortex devoted to it. In other words, the more fine the movement has to be, the more real estate on the cerebral cortex you're going to see. Remember when we looked at like the homunculus, for example, right? The homunculus, things in your facial expression that require a lot of like, fine control, like for example, like your lips around your mouth, right? You have to have lots of fine control with those structures. So you're going to see those regions heavily represented by the cerebral cortex. Be familiar with this image. So know if you had damage to this lateral region right here, just above the temporal lobe. So if you get damage above basically the sylvian fissure, that's going to be facial paralysis. A little bit above that is going to be upper extremity. Towards the top portion of the brain, you're going to see truncal paralysis. And then when you get into the medial portion of the brain, that's going to be lower extremities, so lower appendages. So make sure you know those different regions and what they represent. And again, face, that's going to be cortical bulbar tract, right, versus everything else is going to be cortical spinal tract. Medial and lateral cortical spinal tract. Now, when we talk about cortical mapping, this is just areas of the brain that are going to be dedicated to different types of motor control. So this is a cortical map, which is going to be a map of intention of movements or goals of movement. So it can involve, of course, behavioral aspects of movement. Here's studies that were done where they were stimulating regions of the brain and seeing how that would affect the muscle contractions. So you can see spike trigger averaging, which basically allows you to study how stimulation of the brain will result in actual motor control and motor function. And then you can see the muscle field, which is going to be the receptive field that's receiving signals from the brain to allow for movement. Now notice over here, you have the actual spike and stimulation of the muscle movement, and then you have a latency period, right? What do you think that latency period corresponds to? That little red spot on that graph. Not quite a refractory period. It's a latency period. Remember, refractory period means that if you're stimulating a neuron, you're not going to get an action potential, right? Once you get the absolute refractory period, you're not going to get an action potential again. But that's not related to this. It's a little bit of a different concept. So it kind of goes in line with what we measure in EMGs, right? What are we measuring when we do an electromyogram?
Electrical activity of the muscle.
That electrical activity in the muscle, yes, but something else too.
The speed of the electricity.
Yeah. So the velocity, right? How long it takes for that actual initial signal to reflect in a muscle contraction, right? Or to result in a muscle contraction. So this red portion right here, that's kind of the same idea, right? So that's kind of like the latent period between the actual stimulation and then the muscle contractions itself, right? So that's kind of what's going on in that graph. So pretty cool stuff. They measure the nerve conduction velocity. So yes, they will measure the electrical activity of the muscle. When you stimulate a nerve, so for example, like in my lab, what we do is we shock the median nerve, and we have electrodes that we place so we can measure the actual contraction of the muscle. So we shock the median nerve at the elbow, for example, and we see how long it takes for you to actually get a contraction of the muscle. So you shock, that's time 0.0, and then you see what the delta t is, the delta time, right? And then you see the delta d, which is the change in distance, and then you can actually see what the meters per second are in terms of the actual conduction velocity of the motor neuron. So there's always going to be a delay. There's going to be a delay, right? It's not immediate, but it's pretty damn close. It happens very rapidly, but it's like to us, like we barely even notice it, right? Like if you want to move your hand or something, it's basically immediate. But there's a lag period in reality if you actually measure it. So spike-triggered averaging. So this is the technique can be used to determine all the muscles that are influenced by a given motor neuron. Right? So you're stimulating the part of the motor cortex. You get that little delay, and then you can see all the motor units that are going to be involved in that. All the muscle groups are going to be involved in that region. When you're stimulating that region, corresponding, for example, to the muscles in the hand, allowing for contraction of those muscles. So that's spike-triggered averaging. Also, other things that are important, right, with the primary motor cortex, this is going to be, again, responsible for voluntary and purposeful movements. And so you can see somatotopic mapping of behaviors, right? You can see a map of, the different regions of the brain that correspond to different types of movements. Have you guys ever seen this video before? It's absolutely freaking incredible. Like, if that dude missed the water silo, I'm pretty sure he wouldn't survive the fall. So pretty wild stuff. Love skateboarding, but amazing stuff. Stimulation of those regions of the brain. So here's some studies that were done in monkeys where they were stimulating the primary motor cortex and seeing what kind of movements would be elicited. So in this study, blue was the starting position of the extremity, maybe the hand or whatever, and then the final position was marked in red, and so blue to red, right? And they were just like stimulating different parts of the motor cortex and seeing which ways and which directions the monkey's arms would move. So fun stuff. Now, here's some other things. So movement and direction. So directionality. So this is population code and vector. So vector just basically just means the direction of a movement, right? In three-dimensional space. The more precise the movement, the larger the number of upper motor neurons are required to integrate into the circuitry. Okay, so remember, precision requires more real estate in the brain to allow for that movement to actually take place. And then directionality, that's going to be in vector measurements. And so this is very much FYI. I'm not going to test you guys on all of this stuff, but this is basically showing kind of like the directionality of movement. Different neurons, when they get stimulated, are going to have different preferences of direction that they want to move in. And so that's what these studies were looking at. Again, that is going to be FYI. But neurons do have a preferred direction, right? So different neurons are going to be involved in different types of directionality. And so here's a population vector. This basically shows the direction whenever you're stimulating the neurons, which direction the neuron's going to want to move in, which direction it's going to want the actual appendage to move in. So different angles, for example. Again, all this is FYI. Now, again, here's the premotor cortex. That's going to be kind of like the motor association cortex, right? So premotor cortex is the same thing as the motor association cortex. That's when you're basically formulating the idea of wanting to move, right? You're kind of coming up with the idea, right? You haven't done it yet, but you're just thinking about it. And it involves a very complex system that has to correspond with the basal ganglia and all the different nuclei involved in that. So you have the striatum, you have also parts of the brainstem that produce dopamine, like the substantia nigra. And so the whole basal ganglia is going to be very much involved in this whole process. It kind of gives you the green light to allow for actual movement. When you actually get to do the actual movement, that's going to take place at the primary motor cortex. So premotor cortex, think about it as being kind of like the behavioral part of movement, right? You're formulating a thought that's going to result in an actual movement. Cingulate motor areas. Again, remember, the cingulate cortex is going to be very much associated with emotion, right? That's going to be involving like integrating emotion, processing emotion, and then it's going to correspond with those motor areas to allow for movement as a reaction to emotional stimulus. So cingulate motor area, very important for that, right? Connecting emotions to movement. Here's some fun stuff involving minds and machines. Again, this is another thing I'm not going to go in detail for you guys, but this is, if you want to do further reading, feel free to do so. Right? This would be especially pertinent to anybody who's going into like biomedical engineering. So biomedical engineering, where they're trying to figure out how to maybe like connect prosthetics to the brain so that you can actually, you know, if you have to get like a new limb, right? Trying to figure out ways that you can actually use neuronal firing and neural signaling to allow for movement of a limb. So this is really cool stuff. Lots of research going to that, especially in biomedical engineering. Yeah, I'm not going to go into any of these. This is all just for your own reading if you're interested in that stuff. Now this is really interesting. This is, again, the mirror motor neurons. So literally they fire when you're seeing somebody do something. Right? If you're seeing somebody move their hand and you're going to maybe have to do something similar, these neurons get stimulated just by watching somebody do a movement. I mean, first and foremost, when we learn things, right, we're very much a mimetic animal. We learn by observing. That's critical. You have to watch something being done so that you can actually learn how to do it yourself. So this is very much involved in that, right? Allowing for learning, allowing for goal, direct type movements, right? So super important. Mirror motor neurons respond less when the movement is not goal directed. So it has to be goal directed. It has to be something that you basically are going to be doing yourself. So in this case, this had to do with measuring the mirror motor neurons in a monkey while they're observing food being moved around on a tray. And so literally when the researcher was moving food on the tray and then giving it to the monkey, you would see similar types of firing patterns, right? But the mirror motor neurons were the ones that were very much being stimulated just by observing the researcher do those movements. So again, it has to be purposeful, so it has to be goal-directed. In this case, involving food, and food is a very powerful, motivating force, right? If any of you guys have pets, or dogs in particular, you know that very well, right? You give a dog a treat and you can teach it how to do so much. There's actually a really cool video that my wife was showing me the other day. It's like this little cool like robotic vehicle, and inside there's like a rat and I don't know who built this thing, but it's like the rat can control the motor, the vehicle, so it can like move around and stuff. And there's like little openings in the window for the rat to get food. So like the owner of the rat was like putting out like little treats and stuff, and then the rat would have to like figure out how to move the vehicle to get the treat. So super, super cool. right? To think that a rat can actually manipulate the movement of like a little tiny car, basically. What's up?
How is it you can like watch something and then replicate that movement? You've never done it. How does that?
You have to practice it, right? If it's something complex, it depends on the complexity, right? If you watch someone play the trumpet and you try to play the trumpet, it's going to sound like a dying elephant, right? Because if you never played the trumpet before, it's not going to sound good, right? Same thing with like watching someone play the piano. Like if you can watch someone do something, but it's going to be hard for you to do yourself. You have to practice it. But for something as simple as just picking something up, that is going to be a little bit more, easier, right? Did I answer your question at all?
Yeah, I just remember like I was talking about that motor control class, and that's like the only time we go into like brain stuff.
Yeah.
And they were saying like this is one of the things that they don't understand. Like how does it? They were saying there's like not enough room in the brain to have all patterns memorized to do everything, but there's also like no way of knowing how you get a new movement to like initiate. And we talked about like if you had a kid that like never sees anybody else, like obviously bad situation, but like people would like lock a kid up in the basement and like don't see anybody else walk, then they just like never learn.
Oh yeah, remember we talked about critical periods before? Yeah, when kids are not able to fully develop during that critical period, those aspects of movement, of even just like social relation, like all that, they're going to be developmentally challenged, and it's permanent. It's like it's never going to come back. And so, yeah, when it comes to we're going to talk about the basal ganglion a little bit later this week. Basal ganglia is also really important for learning how to do things, right? Remember, part of the basal ganglia involves dopamine pathways, which is reward pathways. And it's also there to reinforce behaviors that are beneficial. So when you're learning something new, the basal ganglia basically is getting involved in that whole process by just allowing for the release of dopamine to basically signal reward. Also, development of habits in general, whether it's a good habit or a bad habit, that's also heavily moderated by the basal ganglia. So when you're learning like a new movement, that's also going to be very much involved in those like subcortical regions, like the basal ganglia. So I don't know if that answers your question whatsoever, but like,
definitely helps.
Yeah, they're all like intertwined all together. All these systems have to work with each other for them to function properly. Yeah, so mirror neurons, I mean, that's mirror motor neurons. I mean, that's a really integral aspect of all that too. And that's all part of the premotor cortex, right? That's the motor association area. Some mirror motor neurons are going to be suppressed, suppressing firing when you're observing something. That might be because you're suppressing the actual movement itself, right? So in other words, it's like you're watching the movement and you know that you're watching it. You don't want to be doing the movement as well, right? This can also be seen too in like dreaming, for example. There's a lot of, regions that are going to be lighting up, especially in like motor areas, but there's a lot of suppression of actual movement because, you don't want to be, if you're running in your dream, you don't want to be like running around in your bed, right? So there's, these kinds of suppressive mechanisms come into play as well when you're seeing these mirror motor neurons come into play. So super cool. So these are all the different regions of the brain that are going to be associated with, for example, reaching to grab something, right? So all these different regions are going to be involved. So you have visual cortex. You have to see what you're trying to reach for. So visual cortex is going to be involved in that. You also have the temporal regions, which are going to be involved in that process as well. Then you have parietal regions, which are going to be important for proprioception, sensory input, right? And then you have your premotor cortex, which is allowing for integration of emotions, goals, the idea of actually initiating movement. And then you have them communicating with different regions in, for example, the premotor cortex, prefrontal cortex, and then eventually you have actual primary motor cortex coming into play. So this is a complicated system, but it all has to work together. So you can get integration of all the different regions of the brain so you can actually initiate movement. So super cool stuff. So axial trunk and proximal limb muscles. Again, we talked about the cortical spinal tract as well as the vestibular spinal tract. the cortical bulbar tract. But now when we look at the vestibular spinal tract, this is a little bit different. The vestibular spinal tracts are going to be integrating the vestibular system. Remember, vestibular system there is there to allow you to figure out what your balance is like, your posture, kind of like your orientation in three-dimensional space, right? And so the vestibular spinal tract gets initiated, especially if you're, for example, falling down, and then you have that reflexive urge to put your arms out to catch your fall, right? So this will come into play as a protective mechanism, right? So if you're like losing balance, if you're falling down, if you have to have like a really quick reflex to protect yourself as you fall, this process is involving the vestibular spinal tract. Other areas that are important, the reticular formation is also really important. Remember, reticular spinal tracts, reticular formation, that's all there for alertness, awareness, right? Consciousness. Consciousness is very much associated with the reticular regions in the brain. So the reticular formation is going to be involving basically the entire brainstem. Midbrain pons and medulla are all going to have reticular formation within them. Different parts are going to be associated with different areas of the brain. So forebrain activity, that's going to be more of like the mesencephalic rostral pons. And then when you get down below to the caudal region, that's going to be involving more like premotor coordination. But long story short, again, consciousness. Reticular formation is very important for consciousness. When you render somebody unconscious, like for example with like anesthesia, remember that involves this, right? You're basically putting this down. You're reducing neuronal firing within the reticular formation. Now with the premotor region, so you get modulation, right, of consciousness, but then you also have modulation of things like visceral and somatic motor neurons as well. So things like, posture, coordination of your eyesight, right, where you're looking at, especially if your head's moving, right, you want to make sure you fix your gaze at an object. Other things are involved in the brainstem, right, like yawning, gag reflex, all that stuff. Your autonomic function is going to be very much heavily involving the medulla in particular, right? And so the reticular formation is going to play a role in all those types of functions. In terms of posture, this is going to be involving a lot of your muscle groups. They all have to communicate together to allow maintaining posture. So it's going to be allowing for stability. And then you have anticipatory reflexes that are going to come into play as well. So interesting study over here. This study was involving a sound. Once the sound was initiated, then the participant was asked to basically flex their biceps. In doing so, before they even flex, their gastrocnemius is going to contract before the biceps flex. And that happens reflexively because the gastrocnemius is basically preparing the person to do a movement with their upper extremity. So lower extremities come in first, like just milliseconds before, and then the upper extremity, you actually see contraction. So in this case, again, gastrocnemius contracts first, milliseconds later, the biceps contract. So literally the brain sending signals down to the lower extremities to allow for maintaining posture. And it's all part of anticipatory type of reflexes. So this is considered a feed-forward postural response. Again, this is anticipatory, it's reflexive, so it's basically pre-programmed. And then you also get a feedback mechanism that's going to allow for kind of making sure that the posture is maintained. Right? So you get the central command, that's the feed forward. So your brain basically is sending signals down to the lower extremity to maintain posture in anticipation for upper extremity movement. Then you get the actual limb movement. Then maybe the posture gets a little bit thrown off balance. Then you get a feedback system coming into play to allow for maintaining the posture. So super cool process. I mean, so much is involved in this, and such a short window of time, right? This happens in milliseconds, like really, really fast. this is, again, some review. We got your upper motor neurons. They're going to go through the spinal cord, right? You have different tracts and progressions. You have direct projections down the spinal cord, but you also have indirect projections that are basically going to be going through the reticular formation. Other structures that are important, your superior colliculus. Remember, your superior colliculus is really important for visual integration, right? So you can get kind of like spatial orientation of where you are in like three-dimensional space, as well as audio integration. And then it integrates with the rest of your motor system. So you're basically taking in visual cues, sound cues, and you're using all that to basically maintain your posture. Let's see, is this very important? Kind of goes into what we've already been talking about, so I'm going to skip through that. All right, now let's talk about upper motor neuron lesions. So upper motor neuron syndrome. That's going to be affecting the descending motor pathway. Why is it descending? Because it originates in the cortex, and then it descends its way all down to the brainstem and then down into the spinal cord. This happens, it's not uncommon, right? You have lots of cortex devoted to motor. Right? Whenever you have, whether traumatic brain injury, a TBI, or if you have a stroke, right, ischemic or hemorrhagic, you can see these pathways being affected, right? And so that's going to be damaging the descending pathway. The way the descending pathway goes down, again, let's just refresh ourselves. You have your precentral gyrus, aka the primary motor cortex, going down into the midbrain, and that's going to be passing through the cerebral peduncle, right? That's going to be this structure right here. It's going to be the anterior portion of the midbrain, and it's going to go down until it reaches the medulla. It crosses over at the pyramids, and it's going to go down lateral corticospinal tract, according to this diagram. You also have some fibers going down the anterior corticospinal tract as well, but the majority are going to be lateral corticospinal tract. It's like 90+% of all the fibers are going to be lateral corticospinal. So here's another chart that summarizes upper versus lower motor neurons. Make sure you're familiar with this, right? Especially the stuff that I highlight in red, right? Muscle atrophy. You can see atrophy in both, but it's going to be more severe in lower motor neurons. Reflexes, again, upper motor neuron, hyperreflexia, lower motor neuron damage, hyporeflexia. Upper motor neuron lesions, you're going to see spinal shock happening. That's going to be at the onset of the damage. So you're going to see spinal shock, you're going to see spasticity, and then you're going to see Babinski sign. Clonus, do I have a video of this? It's like tonic-clonic type movements. Right? Clonus is basically just kind of like a jerking type of movement. And so if you were to like manipulate, for example, the foot, I think I have a video of this coming up. If you were to like manipulate the foot, like for example, if you were to draw the foot back, you're going to see the foot now starting to do like a downward type of contraction. That's called clonus. I think I have a video, if I remember correctly. We already know what the Babinski sign is. Upper motor neuron lesions, again, you're going to see impairment of your movements, like voluntary movement. Fasciculations and fibrillations, right? Those are going to be like tiny little spasms, right? Like spastic type contractions in lower motor neuron lesions. It's going to be associated with whatever region is involved, right? So lower motor neuron, that's outside of the spinal cord, right? Where if you sever the neuron, you're going to see deficits in whatever structure those neurons are innervating, right? If it's the neurons that innervate the flexor and extensor muscles of the thigh, then you're going to see deficits there, right? So it really just depends on which regions are innervated by those neurons. So here's spinal shock. So remember, upper motor neuron lesion, the moment you get that, you're going to see potentially spinal shock. And when we say shock, we mean hypotonia, like no movements, right? Because remember, with an upper motor neuron lesion, you're going to see hyperreflexia, and you're going to see hypertonic spastic paralysis afterwards. But on the onset of that lesion, it's going to be spinal shock. You're going to see flaccidity at first. Right? Everything goes flaccid. That's in the short term. Long term, again, you're going to see hyperreflexia. You're going to see the Babinski sign. You're going to see spasticity, and you're not going to be able to have any fine motor control. So again, here's your Babinski sign. Just to recap that, just to bring that back in. So here's muscle tone. Oh, I do have a video of clonus. Good. So muscle tone. Muscle tone is like resting muscle tone, right? It's going to be depending on alpha motor neurons. Which muscle fibers do the alpha motor neurons innervate? Do you guys remember? No. That's gamma. Extrafusal. Yeah, alpha motor neurons are gonna innervate the extrafusal muscles. Intrafusal is gamma motor neurons. So hypotonia, you're basically not seeing any alpha motor neuron effects. Hypertonia, you're going to see descending paths, or it's going to be involving, that's going to be secondary damage to the descending paths terminating the spinal cord. So here's spasticity. You get two different types of spasticity. So here's clasp knife spasticity. First, you're resisting to the movement, and then you eventually just basically give in. Right? So it's called clasp knife spasticity. You initially resist, and then you yield, and you basically go flaccid. And this has to do with the Golgi tendon organ, as well as interneurons coming into play. So I'll play you a video of that in a second. Clonus, again, is rhythmic contraction. Remember when we talked about seizures, tonic-clonic? Right? Tonic was when you like froze up. Clonic is when you start like uncontrollably jerking. That's kind of what's going on with clonus in general. So it's like rhythmic type of contractions, and that has to do with the muscle spindles. So first, let's watch clasp knife spasticity.
This is due to rigidity of the extensor muscles of a joint that gives resistance to passive flexion, but gives away abruptly to allow easy flexion on exertion of further pressure. This movement resembles that of a clasp knife.
So he eventually gives in to the resistance.
A series of catches.
Well, we're not going to watch cogwheel rigidity. Let's watch clonus. So you basically stimulate a reflex, and then you get those rhythmic type of contractions. So for a patient like that, like if they're not having actual clonus, you can induce that. Again, you just push back on the foot and you dorsiflex the foot. So like the foot is, either facing the ceiling or in this case, like facing towards their head, right? And then just that in of itself is going to stimulate this type of clonus reflex. And so again, rhythmic undulations, right? Rhythmic contractions. Sweet. Let's do like 2 questions and then we can continue on with the basal ganglia. Covering lots of ground today. This is awesome. Someone having a hard time logging in, or yeah, is that you? Yeah. Come on, dude. There we go. Good. Looks like most of you got this one correct. That's great. So this individual, after an injury to the brain, is having a hard time with their upper extremities, right? Inability to grasp things and manipulate objects. And so let's look at the image here real quick. Oh, geez. I don't know if I can actually, can I get it bigger? Oh, a little bit bigger. So upper extremity, whoever selected B was correct. Good. Now, what's D? Lower extremity. Good. So medial portion of the motor cortex is going to be lower extremity. What's A?
Face.
Yeah, great. Exactly. What's C? Trunk. Awesome. So make sure you know those regions. Sounds like you guys already have a pretty good grip on it. One more question, then we'll move on. Good. Yeah, mirror motor neurons. Those are going to be activated when you're literally observing someone do something. All right, especially if it is what?
Like purposeful.
Purposeful, goal-directed, meaningful. Yeah, absolutely. Absolutely. All right, I'm going to end it there, and let's go ahead now and get into the basal ganglia.